Hello, everyone. First of all, I'd like to thank Namrata and the AIOS for inviting me to speak. So these are my financial disclosures with no relevance to my talk. So it's important to visualize vitreous, and it's done by adding diluted triamcinolone to stain the vitreous. So this is the first case here. We see that there is actually vitreous in the anterior chamber at the time of presentation in the Subuxated cataract. So we have to attend to any vitreous that's in the anterior chamber because we cannot phaco with it present. So this is introducing a trocar cannula through the pars plana 3.5 mm posterior to the limbus. And because it's a cataract, the capsule is first removed so that I can then anchor the lens to support the lens. And then with the AC maintainer in the anterior chamber, we do a 23 gauge pars plana vitrectomy to remove the vitreous from the anterior chamber. And then we add all the supports to the anterior capsule. And the next important step is to insert a capsule tension ring done just under the anterior capsule, a plane that's been dissected out by viscoelastic. And then we reposition the lens so that no more vitreous presents because that gap is then sealed. So at the end of it, we have a nice stable lens that's been anchored to the sclera. So let's have a look at the next case now. So in this patient, you can see the lens is dipping into the vitreous, and vitreous is all over the anterior chamber. So again, we approach from the pars plana to do an anterior vitrectomy, and we really need to thank Abe for introducing this technique to us and popularizing it. So again, dissociated vitrectomy, infusion from the anterior chamber, from an AC maintainer, and then doing vitrectomy to clear all the vitreous that's in front of the lens. It's very important because we're going to go down to get this lens up into the anterior chamber to anatomical position. You can see only posterior zonules are present that support the lens as I spear with a 27 gauge needle. And once I fixated this lens and taken out the cataract, we then go back to the anterior chamber with diluted triamcinolone acetonide to make sure that there is no vitreous left when we leave the eye. And at the end, after we've stabilized the anterior chamber, we then remove the trocar cannula, which is very useful to leave right to the very end of surgery. So in this next case is a posterior polar cataract that has the posterior capsule is given away. And again, we have to do vitrectomy in here because I have a very good view, no lens fragments left. I'm doing it through a limbal approach. And this is a snug approach and is separate from the main incision so that the fluidics are stable in the anterior chamber. And we're removing vitreous that is already highlighted by triamcinolone acetonide. And following that, we can then begin to remove residual cortex, or in this case, epinucleus. And sometimes it can be a little difficult to remove with a retractor that has been switched to the IA cut mode. But you can do this by switching to just irrigation aspiration. And this is possible because there's no vitreous in the anterior chamber. You cannot aspirate cortex if there is vitreous in the anterior chamber. So after we remove all the cortex, and you can see even coming from the other side, we are doing through a snug incision so that vitreous does not lead forward into the anterior chamber. We have a good outcome here. So this other patient was done by my fellow, and suddenly the anterior capsule ripped, and you can see, and that nucleus is just behind, it's being nudged forward by a cotton bud, right? So there's no vitreous in the anterior chamber. And then we go into the pars plana approach again for vitrectomy. In this case, it happened just very recently. We'd run out of triamcinolone because of the COVID situation. And I'm just supporting the nucleus with my second instrument as I do the pars plana vitrectomy so that this does not drop backwards as we clear the vitreous. And then we are using the assistance of the posterior vitractor to levitate that nucleus forwards once we have cleared the vitreous in that space, and then stabilize the fragments with dispersive viscoelastic, inject a 3-piece IOL into the anterior chamber supported by the iris, and then we go back with phacoemulsification because the incision has not really been enlarged significantly. We can still proceed with normal parameters to remove the remnant hard nucleus without vitreous coming in the way and without fear of snagging vitreous and tearing retina. At the end of that, we go behind the lens again to make sure we have no vitreous in that space, and then we can clear cortex from the capsular bag behind the IOL using a IA cut mode. And in this case, because of the anterior capsule rib, I did an iris fixation. This is another patient with Morganian cataract, and after opening up the anterior capsule, you see it was fibrotic. I had to actually make a cut to complete it. The nucleus actually just began to sink, and I really had done nothing. I had not even done hydrodissection. So we bring this forward, and again, I'm going to approach this from a past planar approach because there's already vitreous in the anterior chamber. So after injecting triamcinolone into the anterior chamber to stain the vitreous, we then cut posteriorly, and it's really challenging to see the cutter through this dense cataract, but you can just make it out, right? So it's important that we go anteriorly and not into the central cavity where we do the cutting. And again, once there's no vitreous in the anterior chamber, we then insert the 3-piece IOL into the anterior chamber supported on the iris, and then tackle this dense nucleus. Fortunately, this was a really high myope with exit length of 30, had a deep anterior chamber, and I could actually phaco a little away from the endothelium. So after this, we then again check for vitreous in front of the IOL, behind the IOL, remove whatever cortical remnants there are, and then manipulate this into the sulcus space, and then we had a good outcome for this patient. So this is when we see vitreous presenting years after surgery, and this is a pseudophakic IOL, EDOF lens, and you can see the vitreous collapsing into the anterior chamber as it is highlighted by triamcinolone again. And we're going to have to do a posterior approach definitely for this case to cut the vitreous, because if you did it from the anterior segment, you would never be able to completely remove it. So you can see as we're doing the cutting, we're pulling the vitreous posteriorly. The infusion comes from the anterior chamber, again with the AC maintainer, the 23 gauge Lewin-Key cannula, which I used there. And once we have removed it from the posterior segment, we then look at the remnant strands of vitreous that are there that are trapped by the capsule. And then we just remove the rest and go back one more time to ensure there are no remnant tufts there. And I then secure this with the capsular tension segment and center the IOL. So you've seen various cases, how we handled this, vitreous at different stages of presentation. So settings for vitrectomy include a low bottle height, a vacuum that is not too high, high cut rate, use a 23 or 25 gauge posterior vitreous cutter, usually about 1,000 to 4,000 cuts per minute, vacuum 2 to 300 mm Hg, and bottle height of 70 mm or about IOP of 30 mm Hg. I generally use about 2,000 to 3,000 cuts per minute. So in conclusion, it's important to stain vitreous and to visualize the vitreous, usually about a third to half diluted triamcinolone. We want to deal with vitreous as it presents in the anterior chamber. Never wipe or sweep the vitreous, it causes retinal retraction. Use biomanual or dissociated vitrectomy, and infusion should always be in the anterior plane. It's important to inform your patient after surgery, the complication, and also important to check the retina for retinal tears. Thank you very much for your attention.
Thank you.